This program is brought to you by Emory University.
Good morning, everyone. Hope everybody had a nice summer. So it is my great pleasure today to introduce one of our own, Dr. David Delurgio, who has graciously reached out to me end of last year and said, hey, I'd be happy to speak. So I always appreciate volunteers, so thank you for that. AFib is such an important topic for all of us. We see so much of it. And so Dr. Delurgio is going to get us up to speed on catheter ablation and AFib update. Dr. Delurgio is a professor of medicine and the director of EP Lab at Emory St. Joe's and former director of the Arrhythmia Center at Midtown. He went to Loyola for undergrad and did medical school, internship, and residency at UCLA, followed by EP fellowship at Emory. He's been involved in many writing groups for many trials. I was just telling him that I didn't realize he was the PI of so many clinical trials at Emory over the years related to EP. He's also the founding member and contributor of the International Cardiac Sarcoidosis Consortium, which I thought was interesting. He's on the editorial board of several EP journals, and his research focus is on cardiac ablation techniques related to AFib, and also testing devices for heart failure and sudden death. He's also the founder and contributor to AFib support group, which I thought was also very important work. So I will turn it over to Dr. Delurgio and update us on AFib.
Thanks very much, Pooja. It's an honor to speak to my colleagues and to kick off the new year of Grand Rounds. So I'm giving you an update on catheter ablation for AFib. It's not so much a technical update as more of a why we do what we do. My objectives are to give you a brief overview of the epidemiology of AFib and to help develop an understanding of the spectrum of pathology in atrial fibrillation. I'd like to re-explore the question of rhythm versus rate control with you. I hope you'll understand the benefits of early ablation for patients with paroxysmal atrial fibrillation, and understand how we are developing strategies for and defining the benefits of AF ablation in patients with different stages of cardiovascular disease. So on the epidemiology side, I think we all know that we have an epidemic of atrial fibrillation. Currently, we're looking at roughly 3 million people in the US with AFib, rising over time. By 2030, we think we'll have a huge number of AFib patients prevalent at 9 to 12 million in the US. So a sort of meteoric rise, perhaps due to a lot of the risk factors that are occurring in AFib, the aging population, lifestyle issues, et cetera. And also very importantly, in part due to our ability to quantify AFib and detect it more easily using a variety of monitoring systems, which we've become more familiar with over time. The issue of physical activity has also gained a lot of attention. We found that there is a great level of activity. Maybe it's definable by a certain amount of minutes per week. Maybe we can call it optimal physical activity. We obviously struggle on a daily basis with patients who are physically inactive, who have obesity. But we also have a large cohort of patients in the US who are on the excessive physical activity side. And all of these pathways developing a protein activation, inflammation, et cetera, are leading to a common endpoint of left atrial enlargement, which really means left atrial fibrosis and development of the substrate for more advanced forms of atrial fibrillation. So whereas just relatively recently, based on our projections about the amount of AFib, I could tell a patient that he or she has a 1 in 4 lifetime risk of developing atrial fibrillation. But it's really even changed just in recent years, where it's now estimated that 1 in 3 of us will experience AFib at some time during our life. Now, of course, the big issue with atrial fibrillation is all the associated problems. AFib is known to increase the risk of stroke, cognitive decline, and dementia, death. These are major factors. And I think as we treat AFib, we obviously are aiming to improve the outcomes of patients with atrial fibrillation. But I think it's been a big question whether our treatments of atrial fibrillation can improve this picture. and somehow have a public health effect. So many of you will remember the AFFIRM trial, which was published in 2002. It was a seminal trial, which unfortunately put us off on the wrong pathway. It showed that a rhythm control strategy was no better than a rate control strategy in patients with atrial fibrillation. But we can now clearly see that the trial was heavily biased. There were side effects to strong antiarrhythmic drugs, which often included chronic use of amiodarone. They had inefficient maintenance of sinus rhythm in the rhythm control group because, of course, there was no real ablation being done at this time. And anticoagulation was managed poorly, such that many people in the rhythm control group had anticoagulation discontinued and suffered in excess of stroke-related deaths. So the result of the trial was that it was perceived that there was very little benefit in restoring normal sinus rhythm. And this has driven a lot of our approach to atrial fibrillation over a number of years, and it's been quite a challenge to get out of this mode. Now, we do have a lot of data now that's very encouraging and argues for rhythm control. This trial, the East AFNet 4 trial, was published early during the pandemic. Very importantly, it's called early rhythm control therapy in patients with atrial fibrillation. This was 2,700 plus patients with early AFib, in other words, a median of 36 days from their first diagnosis of AFib to entry within this trial. Patients were randomized to an early rhythm control strategy or usual care, which is essentially a rate control strategy. The primary outcome was a composite of cardiovascular death, stroke, or hospitalizations for congestive heart failure or an acute coronary syndrome. And there was a median of 5 years of follow-up. The trial was stopped early because of a benefit showed in the rhythm control strategy. So here you can see the breakdown. In the rhythm control group, there was a variety of drugs used, shown here, very rarely amiodarone compared to other drugs, which we would consider safer, and some ablation. By 2 years in this group, ablation had grown significantly. Some patients were on no drug therapy, others were on standard antiarrhythmics, versus the usual care group, where even then we started to see creep in of ablation and drugs over time because of crossover. These are the results from that trial. The usual care group had an excess of the primary endpoint, which is a composite we mentioned of cardiovascular death, stroke, hospitalization for heart failure or acute coronary syndrome. It was a 3.9 per 100 person years versus 5 per 100 person years development, but that is a hazard ratio of 0.79. So this trial really is the new AFFIRM trial, showing that rhythm control, especially early in the course of atrial fibrillation, reduces hard cardiovascular endpoints. Now, the question of dementia has become a huge question for us, and this is something we all are interested in, is how do we prevent cognitive decline? Atrial fibrillation has been clearly shown to be associated with cognitive decline. The obvious reason one might think of is because of embolic strokes, but even independently of embolic strokes, atrial fibrillation increases the risk of dementia significantly, maybe due to microbleeds or the changes in brain perfusion that happen with an irregular heartbeat. Also, issues of inflammatory mediators that are activated in situations associated with atrial fibrillation. So there's a very clear evidence of cellular apoptosis, volume loss of the brain, and cognitive decline with atrial fibrillation. And when we look at large studies categorizing this, we see that all types of dementia are increased in patients with atrial fibrillation, whether it's Alzheimer's, senile dementia, or vascular dementia. Now, it's very clear as well that anticoagulation reduces the risk of dementia in patients with atrial fibrillation. This is a publication from Sweden, where a very large cohort of patients in the entire country were looked at. These are 446,000 patients with atrial fibrillation, no prior diagnosis of dementia. It represents 1.5 million at-risk years, so quite a large database. Baseline anticoagulation, in other words, as soon as patients were identified to have AFib, they were anticoagulated. This was associated with a 29% lower risk of dementia. And an on-treatment analysis showed a 48% risk reduction. And you can see that The amount of time the patient was on anticoagulation was also critical. Those patients who were on consistent or near consistent anticoagulant had the lowest risk of dementia. So this study is very important in defining the role of anticoagulation and also emphasizing the importance of early initiation of oral anticoagulation. Well, then what about ablation and antiarrhythmic drugs? If we assume that anticoagulation is an important backdrop for prevention of dementia in patients with AFib, what about controlling rhythm with antiarrhythmic drugs or doing an ablation? So the first thing that's important to know about ablation is that ablation is an invasive procedure, and it's a left heart procedure. We're ablating within the left atrium for control of atrial fibrillation. And catheter ablation can have an impact on acute cognitive function. In this trial, it's a prospective multi-center randomized control with blinded evaluation. Ablation was standard radio frequency ablation, in other words, implantation of essentially electrofulguration around the pulmonary veins with additional ablation as indicated. These patients had cognitive testing at baseline and at intervals, and there was rigorous follow-up rhythm assessment. Now, what they found was that at 3 months, those patients who had ablation, 14% actually had evidence of some sort of cognitive decline at the 3-month follow-up versus 2% not having ablation. At 6 months, there was an improvement in those patients, fewer patients, 4% who had had ablation versus 2%. And by 12 months, none of the patients who had had ablation had cognitive decline. But there's evidence of an acute effect. And this is important to take into consideration when we're considering an invasive procedure. Now, interestingly, a large portion also had cognitive improvement who had had ablation versus none who underwent medical therapy. And of course, what we saw with the ablation group was improvement overall at 12 months on their AFSS score, a very low burden of atrial fibrillation versus drug therapy in those who had ablation, and a very low use of antiarrhythmic drugs. And I think this trial points out something very importantly, that the only predictor of postoperative decline after ablation was the time spent doing the ablation. In other words, the time within the heart ablating is correlated with this acute cognitive decline. And this is a future argument for us to really understand the role of limiting left atrial dwell time and concentrating on the type of technology that will reduce the acute effects of an ablation. Now, if we look out longer, though, comparing antiarrhythmic drugs in red to catheter ablation with regard to development ablation, a clear picture begins to emerge over time. This is a large database. You can see the number of patients here, 36,000 patients altogether. The risk of ablation over time dementia over time is significantly reduced in those patients receiving ablation of their AFib versus treatment with antiarrhythmic drugs. And other studies show the same thing. This is a large database from Korea, again, showing medical therapy has a much higher incidence of ablation of all types and independent of whether or not the patient has ever suffered a clinical stroke. This is also a recent publication comparing patients who had had AFib and ablation or antiarrhythmic drugs and using a third cohort, patients matched with no history of atrial fibrillation. And in this study, what they showed is that the risk of dementia in patients with AFib can be reduced to the same risk as those never having AFib by performing an ablation. So no significant difference in dementia rates between patients with no history of AFib and those who have had an AFib ablation over a fairly long follow-up period of time. And even this week, there's a report of catheter ablation and low risk of incident dementia and mortality in older patients. These are greater than 65 years old having ablation. It's a large US-based, primarily US-based database that was used, and 20,000 patients in each cohort using propensity score matching. And you can see that through a large range of subgroups, the risk of dementia is significantly lower in those patients having ablation versus no catheter ablation. And importantly, a mortality benefit. Showing mortality benefit in AFib ablation has been somewhat of our holy grail, and we are able to show it in certain subgroups, but it's quite difficult to show that across all patients getting ablation. Certainly, we saw it here. This trial is the Cabana trial. This was a randomized trial, started early, very slow to enroll, and it aimed to show a reduction in some major composite endpoints, which included mortality. Only after doing an on-treatment analysis were we able to show a mortality reduction in this group. You can see the curves here. There is a difference, but it's only when we do an on-treatment analysis versus an intention to treat analysis. Other databases, again, lend to our belief that we can reduce mortality over time. This was another very large database, and you saw a composite endpoint and all-cause death reduction with ablation versus medical therapy for treatment of atrial fibrillation. So what are we doing? How are we approaching patients? Well, what's very important to understand is that AFib varies. There's quite a spectrum in the pathophysiology of AFib. We can consider early AFib, what used to be called lone AFib. This would be AFib in a structurally normal heart, all the way down to more advanced, long-standing persistent, or what's sometimes called permanent or chronic AFib, and where there is evidence of remodeling of the left atrium and other structural problems in the heart. So we're really talking about someone who has a normal heart on the one end, the early AFib, progressing through various stages to more advanced AFib. Now, this is a CT scan of a left atrium shown from behind. These are the left pulmonary veins and the right pulmonary veins. And the pulmonary veins are the trigger for atrial fibrillation, most clearly demonstrable in the early stages. The color represents voltage, and you see a homogeneous purple color in this instance. This represents high voltage. This is a young patient with AFib with a structurally normal heart and no evidence of fibrosis or scar tissue when we map. This patient is going to be treated with pulmonary vein isolation alone, whether we freeze these veins or we ablate around them to isolate them, because it's the triggers within these veins that is causing the atrial fibrillation. But as we move down the spectrum, we're going to get something quite different. If we look at patients with more advanced AFib, we see a much larger left atrium. We see gradations of color, which represents reduced voltage correlating with fibrotic islands and scar tissue that is formed over time, and a very large left atrial structure. These are patients with much more advanced AFib. This patient has substrate that helps AFib persist, which is why they no longer have paroxysmal AFib. And when we do an ablation, we have to not only concentrate on isolating areas that can trigger AFib, but also dealing with these broad areas of fibrotic tissue that perpetuate atrial fibrillation. And then in between, there are gradations of what we're going to do. Every patient will be assessed for their status, where they are on that spectrum, and that helps inform the type of ablation that they're going to receive. So these are some important studies that also came out quite recently that help us understand what we can do with ablation. This study was called the Stop AF First trial. So this is first-line use of ablation in patients with early paroxysmal atrial fibrillation. We had 203 patients with paroxysmal AFib, no previous treatment. They're randomized to medical therapy, or in this case, cryoballoon pulmonary vein isolation. Cryoballoon is a tool we put up against the ostium of each of the veins, and it ablates, producing a small scar around each vein, which then blocks egress of ectopic beats, which tend to trigger atrial fibrillation. So we had 104 patients in the ablation and 99 patients in the drug therapy group. A gargantuan difference at 12 months in the incidence of recurrent atrial fibrillation favoring ablation, as you can see here, 74.6% of patients free of arrhythmia versus only 45% on antiarrhythmic drugs. This led to the approval of this therapy as a first-line therapy, in other words, not having to fail an antiarrhythmic drug first. In the very same issue of New England Journal was the early AF trial. This is a very similar trial, 303 patients with paroxysmal AFib randomized again to the same therapy, pulmonary vein isolation with the cryoballoon versus drug therapy. In this study, all patients received an implantable loop recorder, which provides dramatic and consistent evidence for what the true arrhythmia burden is over time. The same result, ablation was strongly superior to medical therapy for reducing atrial fibrillation. And very importantly, when we look at the percentage of time in AFib, assuming as we do that we cannot cure AFib entirely, we expect patients to have some episodes of atrial arrhythmia. But when you look at the actual burden between the two groups, not only did they meet a primary endpoint of reduction of any episode greater than 30 seconds, as you saw in the prior slide, but the true amount of AFib that any patient has is extremely low, as evidenced by a full disclosure implantable loop recorder. And this burden reduction, in other words, the amount of time spent in AFib being very low, is something that we're very interested in now, as it appears to correlate with outcomes. Now, what else about ablation? Why are we so eager to do ablation? We've seen that it's very effective, much more effective compared to antiarrhythmic drugs in controlling atrial fibrillation, but also preventing progression. This is another trial that I found very important. It's the ATTEST trial, recent product in Europace. This trial looked at patients who were randomized to PAF or drugs and compared the rates of progression of their AFib to persistent AFib at a 3-year follow-up. In other words, was ablation preventing the AFib from getting worse? And you can see here that there is quite a big difference. In the ablation arm at 1 year, there is a rate of progression of 1.3% versus 6.5%. It continues to grow very rapidly in the antiarrhythmic drug group, such that 3 years of follow-up, 17.5% of patients with paroxysmal AFib had progressed to having episodes of persistent AFib, meaning greater than a week or requiring cardioversion, versus only 2.4% in those who received ablation. In this case, it was radiofrequency ablation. And this is what the curves look like. And it's valid throughout a large subgroup of patients, younger patients or older patients, male or female, left atrial sides enlarged or not, the number of episodes they had had prior to enrollment in the study, presence or absence of heart failure, etc. It's a very valid long-term benefit across a broad range of subgroups. And the early AF investigators, which I showed you early, did a very similar analysis, again, looking at progression. And I just want to show it to you here, showing again that other randomized trials are showing the same outcomes, that antiarrhythmic drug therapy are far more likely to progress to persistent AFib. In other words, your AFib is progressing despite treatment versus those receiving ablation. In this case, it was cryoablation. So whether it's RF or cryo, we are getting the same result. Now, Anshul Patel in our group was involved in this very important trial. As we move down the spectrum of atrial fibrillation, we tend to move away from cryoablation because it is very limited and it's designed to isolate the pulmonary veins only. And we may need to start to consider other substrates. In this trial, the PRECEPT trial, was very important in documenting the safety and efficacy of radiofrequency ablation with or without additional lesions at the judgment of the physician for controlling early forms of persistent AFib. So moving down the spectrum a little bit towards the middle of the spectrum, we tend to move over towards radiofrequency ablation because of its flexibility. The adverse events were quite low. There are no atrial esophageal fistulas or deaths. There were some tamponade episodes that required treatment. There were no strokes. And you can see that it's a good safety profile with reasonably excellent effectiveness at 61 to 2% out at a year. Now let's move even further down the spectrum. Now we're dealing with patients with congestive heart failure. This was a great article showing how the epidemics of heart failure and AFib have collided. In other words, there's a strong relationship between the two. And this sort of slide helps to kind of build that link. We find that AF produces heart failure, which produces AF, and it's a vicious cycle going around and around for a variety of reasons listed here. But the link is quite strong, and patients with heart failure and AFib are far worse off clinically using hard endpoints than patients with heart failure and no atrial fibrillation. So over time, we strove to try and show that ablation is a good thing to do when heart failure patients. Many people are reluctant to consider an invasive procedure because these patients already carry a certain amount of comorbidity. may have significant LV function reduction, and the idea of doing an invasive procedure may seem overly aggressive. But the camera MRI study is a good study to get us started on this. In this study, patients were randomized to rate control, trying to aggressively lower heart rate versus catheter ablation. It was radiofrequency catheter ablation going around the pulmonary veins and also across the roof and floor to isolate not just the pulmonary veins, but the area of the posterior wall, which is also involved in substrate development. And in this trial, it's quite dramatic that the EF improvement in those patients getting atrial fibrillation ablation is significant. This is one of the greatest EF improvements we've seen. Almost all ablation studies show a significant AF improvement in EF, 18.3% versus a very small amount of improvement in those who had effective rhythm rate control with rate control medications. And these findings were still valid even if there was scar present. These were patients who had ischemic heart disease and abnormal atria versus patients without scar tissue present. And I think that this shows us that we don't have to limit ourselves too much in the types of patients we approach with congestive heart failure, because ablation is likely to improve their LV ejection fraction. Fortunately, it also goes beyond just improvement in LVEF. The CASTLE study, CASTLE AF, looked at patients with systolic heart failure below 35% EF with an implanted device that has an atrial lead and can document the true burden of atrial fibrillation. In other words, any episode of AFib can be captured over time. And this was ablation versus medical therapy. This was the first major trial to show a mortality benefit with AF ablation. And so we're looking at a heart failure group. Ablation had a significantly lower risk of death, all cause, than medical therapy with a hazard ratio of 0.56, and also a significant reduction in the risk of heart failure hospitalization with a hazard ratio of 0.53. So improvement of EF, even by only 8% with ablation in this group, correlates to improved outcomes. And there was a reduction of atrial fibrillation burden, of course, which again seems to be the key. Reduce the amount of AFib the patient is having, and you will get clinical results. What about diastolic heart failure? I think we all have finally, naysayers like me who never thought they saw HFpEF, it's all over the place. There is a lot of HFpEF, and it of course correlates with a markedly increased risk of AFib over time. There's a high rate of progression of AFib in HFpEF patients, even when they have no AF at baseline. And if they have AF at baseline, these patients have a dramatically high rate of progression of their AFib over time. But with ablation therapy, there actually is the hope of reducing the impact of AFib and, importantly, improving survival. This study looked at cardiovascular death or hospitalization for heart failure. There's 106 matched patient pairs, ablation versus medical therapy. These are relatively preserved EF in this group. And again, we're starting to see mortality benefit, reduction of hospitalization with ablation versus medical therapy. And this is a very recent trial just presented at European Society of Cardiology in Amsterdam last week and co-published in the New England Journal of Medicine. Catheter ablation in end-stage heart failure with atrial fibrillation. These are patients, 194 in total, with advanced heart failure, treated with goal-directed therapy, then further randomized to either ablation or medical therapy. That primary endpoint was a composite of death from any cause, implantation of an LVAD, or urgent heart transplantation. And there's a quite dramatic difference in this primary income death, LVAD, or transplant. The ablation group is far lower with a hazard ratio of 0.24 versus the medical therapy group. And death from any cause, again, significant improvement. So even in these advanced AFib patients with lots of problems being referred to consider LVAD or transplant, you can reduce this. And in fact, if you look at how many patients went on to get their LVADs, only 1 in the ablation group versus 10, only 1 urgent heart transplant versus 6, And of course, the primary composite endpoint, again, very significant. What we found in this was the AF burden reduction was 31% with ablation versus only an 8.6% reduction in AF burden in those receiving drugs. So this burden reduction is very important. And because of the burden reduction, you have a significant improvement in LVEF in the ablation group versus a very small improvement in those receiving medical therapy. Now, many of you know that Emory has been a big site for development and use of the hybrid convergent procedure for treatment of persistent and long-standing persistent AFib. These are patients with the more advanced forms of AFib. This is a team approach where the surgeon performs epicardial posterior left atrial wall ablation through a subxiphoid window. So make a subxiphoid window, put in a port with video and ablation, a special ablation tool which gets on the posterior wall of the left atrium and ablates this area very thoroughly. This is safer than me trying to ablate it from the endocardium because this faces away from the esophagus and can be more thorough and get transmural lesions, something that's quite difficult for me to do in the lab. And then the hybrid component is us then doing our standard transseptal endocardial approach to complete the isolation of the veins and additional lesions, for example, ablation of right atrial flutter as required, creating a hybrid approach. And in this randomized controlled trial, what we found was that if we do a hybrid approach in all comers, persistent and long-standing persistent AFib, which means continuous AFib for greater than a year, we have a much better outcome compared to standard ablation in this group. And this is a very difficult group to control. So a 50% success rate for standard ablation, that's pretty good. 67.7 with a hybrid approach, a significant improvement. We've also looked at just the group of those patients with long-standing persistent AFib. These are the patients who've been in AFib for a year or years coming to ablation. Many people have been conditioned to think that they have to live with the symptoms and limitations of their long-standing persistent atrial fibrillation, as well as the risk it engenders over time. We did a subset analysis showing even a more dramatic improvement with a convergent procedure versus standard ablation, because again, in long-standing persistent AFib, standard endocardial ablation techniques alone have consistently been quite limited, but we're able to improve on that dramatically with the convergent procedure. And this is that primary outcome at 12, which still holds at 18 months, largely due to a drop-off in the standard ablation. They just tend to do worse and worse over time. So quite a big difference. And even freedom from all antiarrhythmic drugs, we see a great result. So many patients can get off their antiarrhythmic drugs. And this is something that we wanted to show as well, which is what proportion of patients had a greater than 90% reduction of AF burden. And we were able to get close to 79% reduction of AF burden greater than 90%. Remember, these patients have 100% AF burden at baseline. And now you have more than 90%, 79% have a greater than 90% burden reduction. The numbers, of course, much smaller in those receiving standard ablation. So we've also, at our group, this was led by Stacy, looked at the effects of arrhythmia monitoring with an implantable loop recorder, because again, we really like to know the true AF burden when we can. Implantable loop recorders give us great data. Here's someone with the implantable loop recorder. They're in AFib 100% of the time, 24/7. They get their ablation here and then followed over time. In this great example, we see no evidence of atrial fibrillation. We looked at our initial cohort of convergent patients with implantable loop recorders. And what we found is that people still have some episodes of AFib. It's only a little more than 50% of people who have no AFib. However, in this very advanced group, we found that 94% of patients had less than 5% burden of atrial fibrillation. And this is a true burden assessment. In other words, 24/7 ongoing management. And you can see that we're following up out to 450 days here with these patients. So this burden reduction that we're achieving is really what correlates with outcomes. And we see this again in terms of the durability of the convergent procedure. So it's quite exciting. We also looked at a cohort of our patients who had MRIs at baseline and 3 months later. And all patients with an EF of 50 or less had an improvement in their EF with a convergent procedure in this cohort, increasing about an average of 9 points. And the vast majority of patients also showed left atrial volume reduction as well. So positive atrial remodeling with this approach. So these are some good endpoints for us. And I draw your attention to this week in JACC. This is the review topic of the week, and it's definitely worth reading. It gets to AFib burden reduction and how this is correlated with outcomes. AF burden is the stronger correlate to outcomes of AFib than just, say, a recurrence of atrial fibrillation. So while we might say this patient failed ablation because they had a recurrence, it's really how much reduction we've been able to achieve. That burden reduction is our big thing. So we are looking at it as improving quality of life, reducing risks of AFib, including dementia, death, heart failure, et cetera, reducing hospitalization by reducing the burden of AFib. I ask you all to not give up on patients with advanced atrial fibrillation. We've shown that the convergent procedure is very effective and helped through these papers define the appropriate patients who may be good referrals or who are good candidates for the convergent procedure. Now, what about the new kid on the block? You're probably now hearing things about non-thermal ablation or pulse field ablation. The types of technologies I've been describing thus far are all considered thermal ablation. They use either radio frequency to create heat or cryothermal energy to remove heat. But in any case, collateral injury is an ongoing risk, whether we damage the esophagus, producing an esophageal fistula, thankfully quite rare, but also very morbid, or damage a phrenic nerve because we're ablating nearby it, particularly on the right. This could happen with any a thermal technology, and there's also risk of pulmonary vein stenosis. We've gotten good at avoiding these risks, but they still occur, and they're really the biggest thing we have to be considering when we're consenting and deciding to do a procedure is what is the risk of this patient of having an adverse event. Non-thermal pulse field ablation is something new, and we've been doing a lot of work with it here in clinical trials at Emory. The idea is that very short trains of high voltage can be administered through a catheter to the endocardial surface. It will electroporate the cells, and this will lead to cell death without producing a significant amount of heat. And it also has a significantly noticeable specificity for the adjacent cardiac tissue and spares the phrenic nerve in the esophagus. There's been no evidence of esophageal fistula and only maybe one case of significant phrenic nerve injury with this technology. And here you see a catheter designed to apply pulse field ablation around the pulmonary veins. So it's a physiologically different type of cell death that we're getting. Now, we recently published the results of the PULSED AF pivotal trial. This was 300 patients, 150 with paroxysmal AFib and 150 with persistent AFib. These are a couple of my cases just to show what we're doing. The voltage, again, should be zeroed out in the veins. In other words, no impulse can get through into the pulse field line, into the pulmonary veins, or out. That's what we're really trying to do, is prevent egress of signals. And this would be a patient with paroxysmal AFib. We did PVI only. Using the same tool in a patient with persistent AFib, we're able to isolate the pulmonary veins and the entire posterior wall to go after more substrate. You can see this patient with persistent AFib has a larger, more spherical atrium. It's a more diseased atrium, and we did more extensive ablation, versus this patient has a normal-sized left atrium without sphericity or signs of fibrosis. Now, it was very important for us to show safety because that's what we're trying to show, is that we're not damaging the phrenic nerve, we're not damaging the esophagus, and we met that safety endpoint very clearly here. You can see the adverse events are low, and most tend to be related to either catheter manipulation or vascular access site. The treatment success was not extremely remarkable. It's very similar to what you might expect with other technologies in this trial. If we looked at patients with paroxysmal AFib and those with persistent AFib. And of course, this trial is just designed to show that it's efficacious and safe, which I think it did, but it's not as though it cures AFib better than some others. We also just presented at European Society the Advent trial, which was co-published in New England Journal, and this is pulse field or conventional for thermal ablation for a paroxysmal AFib. Now, this is a randomized controlled trial with patient blinding, and the idea was we did pulse field ablation or thermal ablation, and thermal ablation was divided by sites into either RFA or cryoballoon. So we're comparing pulse field ablation to thermal ablation in both forms in a randomized controlled manner with blinding of the patient. And what we found is that it's a non-inferiority design, and pulse field ablation was non-inferior. That's excellent result for us. You can see the treatment effect is actually very good. It's over 70%. And very importantly for us, as we think about what we're offering patients and what we're trying to avoid, such as adverse events, the LA dwell time for this technique is significantly less than that with thermal ablation. And this gets to the point I tried to make earlier about reducing the procedure time. In other words, being more efficient, preserving safety and efficacy, perhaps enhancing safety, enhancing efficacy if we can. This is an interesting trial. No one in this trial had ever used this tool before, whereas all of us have done hundreds and hundreds, thousands of AFib ablations with thermal technology. But even putting this new tool in our hand, maybe doing 2 or 3 roll-ins, we're ready to go and able to spend less time in the atrium and get excellent results with this new technology. So it's very, very promising, still being evaluated. We're doing trials with persistent AFib and other groups. So what are we looking at? We're looking at a lot more ablation out there. I think if you're in the position that you do AFib ablations, you can at least feel comfortable that you have good job security. There's so much of it out there. The guidelines are changing quickly. We have guidelines now for first-line therapy for paroxysmal atrial fibrillation using cryothermal energy. We're working on a trial soon for first-line therapy without drug therapy for persistent AFib. It's all very exciting. And I want to make sure you keep this in mind that every patient is different. There are different points along the spectrum of atrial fibrillation, and they are going to get some kind of different approach, whether we're doing PVI only for the earlier stages, maybe we're doing PVI with additional lesions for patients in the middle, and we might be doing more advanced ablation techniques for those patients who have more advanced AFib. So in summary, all patients with AFib should be assessed for the status of their disease. They have to be offered aggressive therapy. In other words, rhythm control, reduction of AFib burden in order to reduce adverse outcomes, which are a lot of adverse outcomes we went over. But we're talking about stroke, dementia, heart failure, death. A strategy of early rhythm control definitely reduces future hard cardiovascular endpoints, as shown in the trials I presented. Ablation is more effective than drug therapy for preventing the progression of AFib and for the early control of AFib. We have cryoballoon for early patients. We have RF at any stage. We have advanced techniques such as the hybrid procedure. Importantly, those difficult to treat populations like congestive heart failure, hypertrophic cardiomyopathy, others, we certainly want to give these patients a chance at rhythm control or at least rhythm restoration, certainly in the CHF population. Let's not give up on maintenance of sinus rhythm because it reduces mortality, hospitalization, in one study, need for urgent transplant or LVADs. The convergent procedure we've talked about, it's for advanced AFib, and it's been very effective for us here at Emory. And the new platforms are coming along and are going to enhance safety and efficacy, as well as, importantly, efficiency, which is very important in the world of AF epidemic. Thanks very much for your attention. I'd certainly be happy to take any questions.
Great. Thank you, Dr. Delurgio, for that wonderful presentation and summary of all the trials and getting us all up to date. And thank you for being on time also. I'll go ahead and open up for questions. Type in your questions in the chat or raise your hand. I see Mahmoud Abdu has a question.
Yes, thank you. Good morning, everybody. And David, thank you very much for the absolutely fantastic presentation. That was outstanding. And, I have really just a comment and probably a quick question for you is, in the light of the new Castle HTX trial, we can debate the trial and the design of it and all that. However, I find the results of the trial remarkable and tells us what we intuitively had in mind. My question is about going forward with these patients. I anticipate a uptick in the frequency of atrial fibrillation ablation in our population that I see, the advanced heart failure population. Any comments on the peri-procedural risk of these patients and what should we be worried about or look out for that can kind of help you guys out too when we refer these sick patients for AFib ablation consideration?
Sure. For me, we like to have the patient as optimally treated as possible. Of course, patients who come to us in a state of volume overload are at increased risk of adverse events related to their procedure or prolongation of their hospital stay. So volume optimization, of course. Of course, we would like to know the patient's optimally treated. I think that goes without saying. An important point is anticoagulation and assessment of cardiac structure. I tend to image all these patients with cardiac CT, or if there's a contraindication, cardiac MRI, to really look at their left atrium beforehand. This has a lot of benefits. It helps me know what I'm dealing with in terms of anatomy, because I'm going to go in there and work in that anatomy. It also helps rule out a pre-existing left atrial appendage thrombus. And then anticoagulation is critical. All these procedures are performed on uninterrupted anticoagulation, which is a little counterintuitive because there is a risk of bleeding. But we like these. The key thing is to reduce the risk of thromboembolism. So patients come to us, we don't interrupt their anticoagulation. We perform the ablation under heparinization with a very high ACT, and then we continue their anticoagulation uninterrupted with the temporary addition of baby aspirin thereafter. Another group that's kind of hard is advanced renal failure or renal failure with their AFib. Again, if someone's on dialysis, that's actually easier. But if someone's heading to dialysis, we definitely don't want to be a part of that progression. So we have to look at all the patients carefully, but the net is pretty wide.
Okay, great. Dr. Smith has a question.
Yeah, David, great talk. Could you comment on what you think the mechanism of improved outcomes is? Is it reduction in mitral regurgitation, heart rate control? What do you think the underlying results are due to?
Sure. Well, there's a little bit of all of the above. I think that one of the obvious things is we see improvement of EF very consistently. And I think that in many trials, EF is a definite correlate to outcomes.
But why does EF get better?
It's because of improvement in atrial kick, number one. Rate control is another one. And functional mitral regurgitation, which I didn't mention, but you did, has definitely been something we've seen to improve as well. So when a patient has what appears to be functional mitral regurgitation in their heart failure AFib status, before considering mitral valve repair, we would like to restore normal sinus rhythm. And we often see improvements in functional mitral regurgitation. So there, I think, are multiple mechanisms that result in improvement. I showed you some of the data on remodeling as well of the atrium, which goes along with the reduction in functional mitral regurgitation. My data is not strong enough to tell you exactly why patients are.
Yeah, I think it would be helpful to look at some of that. I mean, so for instance, if we see a patient who's in sinus rhythm, but on echo doesn't have any evidence of an atrial kick, are they going to benefit from restoration of sinus rhythm? I've been impressed that patients who have very irregular cycle lengths might be those who are most likely to benefit either from a HIS ablation or from AFib ablation. I think those irregular cycle lengths contribute to different phases of pressures in the heart and in the atrium during the cardiac cycles.
It is true that His ablation and resynchronization therapy is helpful, and ongoing studies are comparing that to AFib ablation.
David.
Thank you, Dr. Brett. Oh, who was that?
David, Steve Clements.
Hi, Steve.
So that was a great presentation. Thank you so much. So I was thinking the same thoughts that Andy has, in that if you ablate one of these individuals with chronic atrial fib and you create a regular rhythm, the heart does not like to beat irregularly. That's been shown in the lab for a long time. You create an irregular rhythm and you decrease the myocardial systolic function of whatever segment you're looking at. So, considering these people that have AV node ablation and a pacemaker, and you regularize their rhythm and watch a lot of them get a lot better versus creating sinus rhythm, which likely is better if you could. If you look at the sinus rhythm and you look at the echo in the longer term, as Andy was thinking, the magnitude and duration of the atrial kick on echo might be something that could be measured to quantitate whether or not it's the regularization of the rhythm or the atrial kick or both, as you mentioned. So I was thinking that like Andy was thinking. And I think there's a lot of hope for this in our people who have irregular rhythms associated with atrial fibrillation.
Thanks. Yeah, I think it's a good area to expand our knowledge.
Okay, thank you. Dr. Rab has a question, and then Dr. Goyle.
David, that was a great talk. So when in the natural history of atrial fibrillation, when you see a patient in the clinic, should you refer them for evaluation for ablation?
It's always the earlier, the better. It's called flattening the curve in my mind. If we get on a patient earlier in their course of AFib, we're going to have a lot better chance of reducing their long-term burden of atrial fibrillation, improving quality of life over a longer period of time. I think it's really the new paradigm is to try to get to AFib as soon as possible and restore rhythm. We want to get them on anticoagulants. I mean, if you ever have a patient who's giving you trouble about anticoagulants, make sure you tell them about its effect on dementia. That usually will change a patient's mind pretty quickly. So we're interested in getting our early shot at restoring sinus rhythm. We have fewer redo ablations in those populations. We have greater efficacy overall. Of course, as you know, we have to play the cards we're dealt, and that's why we have to have techniques for more advanced forms. But we definitely need to think about ablation earlier in the course.
Okay, thank you. Go ahead, Dr. Goyle.
David, that was a terrific talk. Learned a lot from the updates. I have a two-part question. The first is the sense I got was that the hybrid convergence procedure and the pulse field ablation maybe still investigational, not really used in regular clinical practice, or am I mistaken? Are you using those already in prime time? That's the first two questions.
Sure. Well, pulse field ablation is not yet FDA approved. We're doing clinical trials. We anticipate FDA approval of one of the platforms quite soon. But no, they're only being used in the US in clinical trials. It is approved in Europe, and there's a lot of real world data out there. The hybrid procedure is definitely approved. It's approved for long-standing persistent atrial fibrillation. And we do use the hybrid procedure for that population here at Emory. We have great partnership with several of the cardiovascular surgeons who do the procedure for us from the epicardial side. And then we proceed to do the endocardial ablation either the same day or in some cases staged and separated by time. The surgeon can also remove the left atrial appendage at the time of the hybrid procedure, which gives us the possibility of coming off of anticoagulants over the long term.
Great. And then the second question, which is related, is how do we scale up our services for AFib ablation? Just you're showing in increasingly various populations, earlier ablation is better. And I'm just wondering, particularly as we go towards this hybrid convergence approach where you approach it endocardial and posteriorly, how do we scale up our services? I mean, there are only so many EP labs and proceduralists involved, and as you said, this burden is just going to increase over the coming decades. How do we keep up with that?
I think there is that's a good question, and this is the challenge to Emory. We have our day-to-day struggles with the staffing models, and I don't want to editorialize too much, but there are ways to improve efficiency, and many labs in the U.S. have really explored and defined and codified those efficiency measures that allow patients to get their ablation in a timely manner from time of consult to ablation. Of course, most of these patients get same-day discharge, which is also a big plus for patients. But it does require a buy-in from the hospitals. For example, there's been a lot of effort to increase accessibility to our clinics, and we're all aware of those, and we're seeing patients pop up on our clinics at very short notice, et cetera, et cetera. And so we're succeeding there, but we haven't yet figured out how to improve accessibility to our labs. And that's a challenge because this is the interface where our department needs to interact with the hospitals and show them what we need to serve our population.
Okay, great. We'll take our last question from Dr. Chang, who has typed it in the chat. What is your decision point in these CHF patients with AF, RVR versus RFA and ablation for AF?
Yeah, I'm not sure I completely understood the question, but I think the issue
I'm
is.
sorry, Dave, I was in a place where I can talk, but basically the question is a lot of times we have these patients that are in AF, RVR, and we just go for a HIS ablation and CRT. And I guess what I'm trying to figure out is kind of what your decision point is when you make that decision versus just going to AFib ablation.
Sure. Well, so I think let's give a clinical example. Let's say you have a patient who has been on good medical therapy. Their EF is 35%, and they have AFib. It's not well controlled. And you're thinking, hey, this guy needs a defibrillator because his EF is 35%. And we should maybe be considering doing a CRT defibrillator with a HIS ablation because AFib is uncontrolled. I don't want to say that's a wrong answer, but I think a better answer is do the AFib ablation because the patient's EF may be go from 35 to 45 after control of sinus rhythm. It takes them out of the range of needing a chronically implanted device with all the issues associated with that. And you don't have to eliminate their AV conduction. So we really want patients to be considered for rhythm control. Some patients, obviously, they don't pass the eyeball test. They're going to be too sick, But I think that the Castle THX study, which I showed at the very end there, and Mahmoud commented on, shows that even in those patients who are pretty end stage, ablation can be done with relative safety and reduce their need for more advanced therapies. So we find ourselves not jumping into the ICD realm right away. We want to treat them, see if the EF gets better, and then if not, that's where your ICD comes in.
Okay, great. Thank you so much. Thank you, everyone, for joining. It is past 8:30, so we will close. Thank you again, Dr. Delurgio, for that wonderful presentation. Learned a lot. Okay, thanks, everyone.
The preceding program is copyrighted by Emory University.